Stop refilling that prescription before you finish watching this. I mean it. Somewhere in your medicine cabinet right now, there is very likely a pill you've been taking for years. Something ordinary. Something your doctor probably approved without a second thought. Something you can buy over the counter at any pharmacy, and a growing body of research says it may be quietly rewiring your brain toward dementia. I'm not saying this to scare you for views. I'm saying it because I've spent my career in medicine watching sharp, independent seniors slide into confusion, and more often than we'd like to admit, the medicine cabinet was part of the story. I've stood at enough bedsides and sat through enough family meetings to know that dementia rarely announces itself with a single dramatic moment. It creeps in through forgotten names, misplaced keys, a stove left on, and by the time a family finally brings it up at Thanksgiving dinner, months or years of quiet change have already happened. What almost nobody asks until it's very late in the process is the one question I want you to start asking today. What is actually in the bag of pill bottles on the kitchen counter, and could any of it be part of the problem? Let's start with the number that made me change how I practice. In 2015, researchers at the University of Washington School of Pharmacy, led by Dr. Shelley Gray, published a study in JAMA Internal Medicine that tracked nearly 3,500 adults over age 65 for an average of 7 years. Almost 800 of them developed dementia when Dr. Gray's team looked closely at one specific class of medication. People who used the highest cumulative doses had a 54% higher relative risk of developing dementia compared to people who didn't use them at all, and the risk of Alzheimer's disease specifically was 63% higher, 54%. Sit with that for a second. This wasn't a fringe study in an obscure journal. This was JAMA Internal Medicine, one of the most respected medical publications in the world, and it looked at drugs that as many as 37% of people over 65 are taking right now, often without knowing what they're doing to the brain over time. And here's the twist that nobody tells you at the pharmacy counter. The class of drugs sitting at position number 1 on today's list isn't some rare prescription. It's something almost every one of you watching has taken this year, maybe this week, maybe tonight before bed. I'll tell you exactly what it is when we get there, and I think it's going to genuinely surprise you. Before we dive in, I want to know who's actually watching this. Drop your age in the comments and tell me one medication you've been on the longest, 5 years, 10 years, 20. I read every single comment on these videos, everyone, and I want to understand what's really sitting in the medicine cabinets of the people I'm talking to, because that shapes what I cover next. Now let's get into it. We're counting down from 9 to 1, from least concerning to most powerful, based on the actual weight of the evidence behind each one. Number 9 on our list is the sleep aid sitting in half of your bathroom cabinets. First-generation antihistamines like diphenhydramine, the active ingredient in Benadryl and in most over-the-counter PM sleep formulas. Here's the dramatic part. This is a drug people think of as harmless because you don't need a prescription for it. But it was actually one of the primary drugs implicated in that University of Washington study I just told you about. Diphenhydramine is what's called an anticholinergic, meaning it blocks a brain chemical called acetylcholine. Think of acetylcholine like the messenger service that runs between your brain's filing cabinets. It's what lets you form new memories and pull old ones back out. In a younger body, blocking that messenger for one night to help you sleep is a minor inconvenience. But after age 65, your brain already has fewer of those messengers to spare because of natural aging. So anticholinergic drugs hit a system that's already running with a smaller staff. Researchers at Indiana University have shown that regular use measurably shrinks activity in the brain on PET scans, essentially aging the brain faster than it would age on its own. If you take this occasionally for allergies, that's a very different risk profile than taking it nightly for insomnia for a decade, which is exactly what the research followed. If you need help sleeping, talk to your doctor about melatonin or non-anticholinergic options, and take any antihistamine at the lowest effective dose for the shortest time, ideally in the morning if it's for allergies, rather than at night for sleep. Pair any allergy medication with plenty of water and, if your doctor approves, a magnesium-rich dinner, since magnesium plays a supporting role in the same neurotransmitter systems these drugs disrupt. I think of Frank, 74, from a small town outside Columbus, Ohio. Frank had taken a nightly over-the-counter sleep aid for almost 15 years just to take the edge off and fall asleep faster. His daughter noticed he was repeating stories within the same conversation. When his doctor did a full medication review and slowly tapered him off the antihistamine sleep aid under supervision, replacing it with better sleep hygiene and a short course of a non-anticholinergic option, Frank's daughter told me 2 months later he sounded like himself again on the phone. I share that not to promise the same result for everyone, but because it shows how reversible some of this can be when it's caught early. Number 8 is the bladder control medication that millions of seniors take for overactive bladder, drugs like oxybutynin and tolterodine. This one is dramatic because it's prescribed constantly, almost automatically, the moment someone mentions needing the bathroom more often at night. These drugs are anticholinergics too, from the same drug family as the sleep aid we just discussed. And studies out of the University of Washington and a separate large nested case control study published in JAMA Internal Medicine involving more than 58,000 dementia patients and over 225,000 matched controls found that anticholinergic exposure carried a meaningfully higher dementia risk, particularly with heavier, longer-term use. Why does this hit older bodies so much harder? Because your body's ability to clear medications through the liver and kidneys drops by roughly 30% between age 65 and 85, so a dose that was manageable at 60 can accumulate in an older system like water rising slowly in a bathtub with a half-closed drain. The practical fix here isn't to panic and stop your bladder medication tonight. Some incontinence genuinely needs treatment for quality of life and to prevent falls from nighttime bathroom trips. The fix is asking your doctor specifically about newer bladder medications like mirabegron, which work through a completely different non-anticholinergic pathway and tend to carry a much lower cognitive burden. If you do need an anticholinergic bladder drug, pairing it with scheduled bathroom timing and pelvic floor exercises can sometimes let your doctor use a lower dose. I think of Margaret, 71, from a small farming community in eastern Iowa, who had been on oxybutynin for nearly 8 years for an overactive bladder that started after her second knee surgery. Her son, a nurse, noticed she was having trouble following the plot of her favorite television shows, something that had never happened before. When her doctor reviewed her chart and switched her to mirabegron, paired with a scheduled bathroom routine, Margaret's son told me within 2 months his mother was back to calling after every episode to talk through the twists. Again, not every case resolves this cleanly, and bladder medication is far from the only possible explanation for cognitive change, but it's a conversation worth having with your own doctor rather than assuming there's nothing to be done. Number 7 is the older generation antidepressant category, particularly tricyclic antidepressants like doxepin and amitriptyline, which are still prescribed today, often for sleep or nerve pain rather than depression itself. Dr. Gray's research team specifically flagged tricyclic antidepressants as among the most commonly used anticholinergic drugs in their study population. Here's why this matters for an aging brain specifically. Chronic anticholinergic exposure appears to interact with something researchers call anabolic resistance, which is your aging body's declining ability to build and repair tissue, including neural tissue, in response to normal repair signals. Think of your brain's repair crew getting the memo to fix a small pothole, but after 75, that memo arrives late, and the crew is smaller to begin with. Add a drug that's actively working against the repair signal, and the pothole has more time to widen into a crack. If you're on an older tricyclic antidepressant for pain or sleep, ask your doctor whether a newer, non-anticholinergic alternative, like an SNRI, could do the same job. Timing matters too if you must stay on one. Taking it several hours before bed rather than right at bedtime can reduce next-day cognitive fog, and pairing it with a consistent sleep schedule can offset some of the disruption to your natural rest cycle. Number 6 is a category that surprises people because it's associated with severe mental illness, but is actually prescribed constantly to dementia patients themselves for agitation. Antipsychotic medications like risperidone, quetiapine, and haloperidol. This is a strange, almost tragic irony. In modern medicine, these drugs are sometimes given to calm the very behavioral symptoms of dementia, yet a large 2024 population-based cohort study found that antipsychotic use in people already diagnosed with dementia was associated with a substantially higher rate of serious adverse outcomes. And the U.S. Food and Drug Administration has carried a black box warning since 2005 about increased mortality risk in older dementia patients treated with these drugs. Separately, a prospective cohort study following over 415,000 participants examined whether antipsychotic exposure itself was tied to new dementia diagnoses, and researchers have pointed to neurotoxic effects on working memory documented even in primate studies. For an aging brain, antipsychotics work by blocking dopamine pathways that are also involved in movement and motivation, and older brains already have reduced dopamine reserve. So the blockade lands harder, similar to turning down the volume on a speaker that's already whispering. If a loved one with dementia is on an antipsychotic for agitation, ask specifically whether non-drug approaches, routine, music, reducing overstimulation, familiar objects and photographs nearby have been tried first, since national guidelines in the United Kingdom and the United States recommend antipsychotics only when those approaches have genuinely failed. If medication is genuinely necessary, ask for the lowest effective dose with a scheduled reassessment date, not an open-ended prescription that quietly renews itself year after year without anyone revisiting whether it's still needed. Pairing any necessary antipsychotic use with consistent daily routines and predictable caregiving patterns can sometimes allow a lower dose to do the same job that a higher dose would otherwise have to do alone. Number 5 is one that catches almost everyone off guard: opioid pain relievers, the same medications prescribed after a hip replacement for chronic back pain or for arthritis flare-ups. A Danish nationwide study presented at the 2023 Alzheimer's Association International Conference followed over 75,000 adults 65 and older who already had a dementia diagnosis and found that starting an opioid was associated with a 4-fold increase in death within 180 days compared to those who didn't start one, with the risk climbing to roughly 11-fold in just the first 2 weeks of use. A separate national cohort study of more than 91,000 people found that opioid use, specifically in the 75 to 80 age range, was tied to a 39% higher risk of developing dementia in the first place. The proposed mechanism involves opioids promoting a kind of cellular self-destruction in brain support cells called microglia, and in neurons themselves, think of microglia as your brain's cleanup and security crew, and opioids appear to convince some of that crew to shut down early. Combine that with reduced kidney clearance in older age, and a dose that felt fine at 60 can sit in the system far longer at 80. If you're on a long-term opioid for chronic pain, ask your doctor about a structured, supervised taper toward non-opioid alternatives. And if opioids remain necessary, ask specifically about the lowest effective dose and regular reassessment, plus adequate hydration, since dehydration compounds the drug's effect on kidney clearance and cognition together. I want to pause here for a moment because if this is helping you see your own medicine cabinet differently, hit subscribe and tap that like button. Right now, it genuinely tells me to keep making videos like this instead of the fluffy stuff, and it helps this information reach someone else's parent or grandparent who needs to hear it before their next refill. Okay, back to the countdown, because numbers 4 through 1 are where the evidence gets even stronger. Number 4 is a medication so common that entire supermarket aisles are devoted to it. Proton pump inhibitors, sold as omeprazole, esomeprazole, and pantoprazole, taken for acid reflux and heartburn by tens of millions of people, often for years without ever revisiting whether they still need it. A landmark German study led by researchers at the German Center for Neurodegenerative Diseases in Bonn, published in JAMA Neurology in 2016, tracked over 73,000 adults aged 75 and older using claims data from a major German health insurer and found that regular proton pump inhibitor use was associated with a 44% higher risk of developing dementia. A separate cohort study out of Taiwan following more than 15,000 adults found a similar pattern, with an even sharper increase among users who also had depression or heart disease. Why would an acid-reducing stomach drug touch the brain at all? One proposed pathway involves the gut-brain axis. Think of your gut lining as a security checkpoint that normally keeps certain molecules out of general circulation. Long-term acid suppression appears to alter gut bacteria and gut permeability in ways that may allow more inflammatory signals to reach the bloodstream and eventually the brain, adding fuel to the chronic low-grade inflammation that already accelerates with age. It's worth saying plainly that not every study agrees. Some more recent prospective analyses, including a large cohort study published in the journal Gastroenterology, have found no clear association between proton pump inhibitors and dementia risk once other factors were accounted for. So this remains genuinely debated in the research community rather than settled fact. That kind of scientific back and forth is normal, and I'd rather show you the honest, messy picture than pretend certainty where there isn't any. Still, given how often these drugs are prescribed indefinitely for mild symptoms, it's worth asking your doctor whether you actually still need daily dosing, or whether you could step down to an as-needed schedule, or try a different class entirely, like an H2 blocker for milder symptoms. There's also a separate, well-established reason to periodically revisit long-term acid suppression that has nothing to do with dementia debates at all. Chronic use has been linked to reduced absorption of vitamin B12 and magnesium, both of which your nervous system depends on directly. So even setting the dementia question aside, a yearly review of whether you still need the same dose makes good medical sense. Pairing any acid-reducing medication with smaller, earlier evening meals, avoiding lying down right after eating, and cutting back on late caffeine can sometimes reduce the reflux itself enough to lower your required dose or allow your doctor to space out how often you take it. Number 3 is one I mentioned would surprise you, and here it is. Benzodiazepines, the anti-anxiety and sleep medications sold under names like Xanax, Ativan, and Valium, along with their close cousins, the Z drugs, like Zolpidem, better known as Ambien. This category has one of the largest bodies of research behind it of anything on this list. A widely cited 2012 study published in the BMJ, following over 1,000 adults with an average age of 78, found a meaningfully elevated dementia risk among new benzodiazepine users. And a 2019 systematic review pooling multiple studies found an overall 38% higher odds of developing dementia among benzodiazepine users compared to non-users. I'll be straight with you. This is genuinely one of the more contested areas in dementia research. Some large, well-designed studies, including a 2016 BMJ study out of the same University of Washington research group, found the association weakened or disappeared entirely at the highest exposure levels, which raised the possibility that early anxiety or insomnia symptoms of undiagnosed dementia might be driving people toward these prescriptions rather than the other way around. That nuance matters, and I'd be doing you a disservice if I pretended the science were more settled than it is. What we do know clearly is that benzodiazepines cause immediate, measurable impairment in reaction time, attention, and short-term memory in older adults, even after a single dose, because they enhance a calming brain chemical called GABA that, in already slowing older neural circuits, can act less like a gentle dimmer switch and more like pulling the plug entirely for hours at a time. If you've been on one of these long-term for sleep or anxiety, please don't stop abruptly. These require a slow, medically supervised taper, sometimes over many weeks, because sudden discontinuation can be dangerous. Ask your doctor about cognitive behavioral therapy for insomnia, which has research support as effective as medication for sleep without any of this risk. And if anxiety is the driver, ask about non-benzodiazepine options that work through different pathways. Number 2 is one that doesn't always make these lists because it's used for such a wide range of conditions that people don't think of it as one thing. Corticosteroids, medications like prednisone, prescribed for everything from severe allergic reactions to arthritis flares to autoimmune conditions, often in short bursts, but sometimes for months at a stretch. Corticosteroids work by mimicking your body's own stress hormone, cortisol, and chronically elevated cortisol has long been shown in aging research to affect the hippocampus, the brain's primary memory formation center. Think of the hippocampus like a librarian sorting new books onto shelves every day. Cortisol, in short bursts, is actually a normal part of that filing process. But when the librarian is flooded with far more books than she can process, for months on end, filing errors start piling up, and eventually some shelves get damaged from overuse. In an aging brain, where the hippocampus has already shrunk somewhat, and mitochondria, the tiny energy factories inside brain cells, are already producing less usable energy per cell than they did at 40, that extra cortisol load lands on a system with far less reserve capacity to absorb it. If you're on a corticosteroid for a chronic condition, ask your doctor whether the lowest effective dose is being used, whether a steroid-sparing alternative exists, and whether your course could be tapered rather than continued indefinitely. Pairing steroid treatment with resistance exercise, even light strength training approved by your doctor, has been shown to help offset some of the muscle and bone effects of steroids. And there's reasonable evidence that regular physical activity supports hippocampal health independently, which may help buffer some of this cortisol burden. And now, number one, the one I promised you at the start of this video, and the one that I think most people watching are taking without even realizing it. It's not a single drug. It's the cumulative anticholinergic burden of everything we've talked about today stacking on top of each other in the same person at the same time. Remember that University of Washington study, the one with the 54% higher dementia risk and 63% higher Alzheimer's risk? That number wasn't from one pill. It came from adding up the cumulative dose of multiple anticholinergic medications a person took over roughly a decade, the nightly sleep aid, plus the bladder medication, plus the older antidepressant, plus an antihistamine for allergies, taken by the same 70-year-old at the same time, each one seeming perfectly reasonable to the doctor who prescribed it because no single doctor saw the whole stack. Think of it like a delivery truck taking on packages from 5 different senders who have no idea the others exist. No single order looks too heavy. But the truck's axle doesn't care whose package it is, and eventually the total weight is what breaks it. This is why a full medication review with your primary doctor or a clinical pharmacist matters so much more than any single decision about any single pill. Ask specifically for what's called an anticholinergic burden score or cognitive burden assessment. Many pharmacists can calculate this in minutes, and it accounts for every prescription and over-the-counter medication you're taking together, not just one at a time. Pair that conversation with bringing an actual physical bag of every bottle in your house, prescription and over-the-counter both, because most people, understandably, forget half of what they're taking when asked to just list it from memory. Include the vitamins, the herbal supplements, and anything you only take as needed, because those add-on medications are exactly the ones that slip through the cracks between doctors and end up quietly padding a burden score nobody's calculated. I think about Dorothy, 69, from a quiet suburb outside Sacramento, who came to a colleague of mine on 5 different medications from 3 different doctors, none of whom had ever spoken to each other. Individually, every single prescription made sense. Together, her anticholinergic burden score was through the roof, and her family had already started quietly researching memory care facilities. After a careful, months-long deprescribing process done properly under medical supervision, not something anyone should attempt alone or overnight, Dorothy's word-finding difficulty improved enough that she went back to doing the crossword puzzle she'd given up on. I share her story not as a guarantee, because not every case of cognitive decline is medication-related, and dementia has many causes beyond what's in a pill bottle, but as proof that this conversation with your doctor is worth having. Here's what I want you to walk away with today. Getting older does not have to mean losing yourself. It does not have to mean losing the independence to drive to your own grocery store, to remember your grandchildren's names without hesitation, to live in your own home on your own terms for as many years as your body will allow. Independence at this stage of life isn't a small thing to protect, it's everything. It's the difference between visiting your grandchildren and being visited, between telling your own stories and having someone else tell them for you. So much of what we've talked about today isn't about fear, it's about awareness. Because awareness is the one thing that puts the power back in your hands and in the hands of the people who love you. Every single medication on this list serves a real purpose for someone, and none of this means every prescription is a mistake. It simply means every prescription deserves a second look, especially when it's been years since anyone actually asked why you're still taking it. It is never too late to ask a better question at your next doctor's appointment. It is never too late to request a full medication review. It is never too late to protect the version of yourself that you want to still be 5, 10, 20 years from now, sharp, capable, and fully yourself. That is genuinely the whole reason I make these videos. All of the studies I mentioned today, the University of Washington research, the JAMA neurology proton pump inhibitor study, the Danish opioid study, and every other source are linked in the description below so you can read them yourself and bring them to your own doctor. And please, before you change anything about any medication you're currently taking, talk to your doctor or pharmacist first. Nothing in this video is a substitute for that conversation, and stopping some of these medications abruptly can be genuinely dangerous. If this video opened your eyes to something in your own medicine cabinet, subscribe to this channel because I put out new videos every single week breaking down exactly this kind of research in plain language, without the jargon and without the fear-mongering. And I want to leave you with one question for the comments below. Which one of these 9 surprised you the most, and are you going to bring it up at your next appointment? Maybe it's the sleep aid you've relied on for years, or the bladder medication nobody ever questioned, or realizing how many small prescriptions have quietly stacked up in your own kitchen cabinet. Whatever it is, I want to know, because your answer might help someone else scrolling through these comments finally have that conversation with their own doctor. I'll be reading every answer. I'll see you in the next one.